Hi, so I'm Dr. Amanda Lee. I am going to talk to you today about prescribing in children and in pregnant women and women who are breastfeeding. The presentation is aimed at district nurses, community nurses, school nurses and anybody who's doing the basic prescriber course and who just wants a bit of an overview on pharmacology, pharmacotherapeutics and kinetics in children, pregnancy and breastfeeding. This is intended as a taster course. It's not going to be really in depth. I'm just going to try and get across to you what sort of things that we need to consider when we are thinking about any medications that are given to children, to pregnant ladies or to people who are breastfeeding. So as the slide says, the objective of this whole session is just to make sure that people are aware of safe prescribing practices and understand the differences between pregnant breastfeeding women and in children as well. So just to give you an overview of how that's different to prescribing, for example, for adults or elderly. It's also there to try and get you to understand the needs of pregnant and breastfeeding women and give you an idea about how you as district nurses, health visitors, school nurses, community nurses can just help with any of these groups of individuals. You may well not come into contact with them, you may well not be prescribing for them, but it's really important. You know, you come and see these people every day. It's really important that you do actually understand how things might be slightly different. And equally, you will be asked questions on this in your assessment as you go along. So 3 fundamental points for the NMC. The Nursing and Midwifery Council offer a code of conduct for all of us UK-based nurses. 3 principles here. One of them is just making sure that if you are going to advise or prescribe, supply or dispense or administer any treatment or medication for anybody at all, we have to make sure it's compatible with the rest of the type of treatments that they're receiving. When we're talking about prescribing, it's always really worth just saying what sort of over-the-counter medications are you taking and how can you take those into context and are there going to be any side effects. There's also a section in the NMC code about safe storage of medication. So we must always make sure that we store and retrieve and hold any medications in a secure manner. Wherever possible, we must always avoid prescribing for ourselves or for anybody with a close personal relationship. And that's just really the ethics of prescribing as well. So I guess it goes without saying that you can only ever prescribe if you've got the relevant knowledge and competency, if you have the skills and experience in managing looking after children, prescribing for children. It's really, really important when you're in a primary care setting and especially in out of hours and general practice. We must never prescribe over and above our own competence. Anyone prescribing for a child in situations such as out of hours general practice or whatever else, you must always be able to demonstrate how competent you are to prescribe for these children. If you're not competent, you must always refer to a different prescriber. And then that way you're working in a multidisciplinary context and you're making sure that your safe use of medications and safe prescribing of medications and monitoring of the effects of those medications is maintained at all times. So if I'm going to prescribe a medication for anybody whatsoever, the first thing that I need to do is to be able to assess them, undertake a full, sound, thorough physical assessment. I must be able to make a diagnosis and to identify and generate treatment options that I'm going to look at to see which ones are the best. This includes pharmacological and non-pharmacological interventions. So I must make sure that I'm competent to do that. So assess, diagnose, look at the treatment options available and then form a decision. This has to be obviously on evidence basis as well. So I have to know all of the evidence that's around to be able to make that decision informed by evidence. You must also be able to assess when you need to start to make an appropriate referral, when you can prescribe medications, when it's appropriate to do so. And equally, whether or not you need to refer back to a medical practitioner or a clinical specialist or a clinical consultant with a speciality in the particular treatment and diagnosis that you're dealing with at the time. The most fundamental question is, are you competent? If the answer is yes, I am absolutely satisfied, I am competent to make this prescription, then that's fine. I always put this slide in because this lecture is to many people who perhaps won't necessarily be coming into contact with pregnant women, women who are breastfeeding, prescribing for children. But in many ways, you're there going to visit in houses, into families. You might well be coming into contact with children who are taking particular medications. So it's really important that you really sort of do understand and grasp that sort of, what are we doing? Why are we prescribing in those sorts of situations? What type of things are we prescribing? How will it affect these people? And how will it affect them differently? You're a healthcare professional. As a healthcare professional, you may well be asked questions on any type of thing. I'm sure you have. I've certainly come across many occasions in clinical practice when people ask me lots of different questions that are completely out of my competence. But sometimes it's really just important just to have a background basic knowledge, and that's what I'm trying to do today with this particular lecture. So this next slide, set of slides, will talk to how we prescribe in pregnancy and the differences that happen during pregnancy, the different physiological differences and changes that happen in pregnancy, which make prescribing particular medications slightly different. You have to remember you're prescribing a drug which has the potential to affect two people, the mum and the fetus. So we must always consider the effects and the after effects of those types of things. The other consideration as well for prescribing in pregnancy is the thought of, for example, folic acid supplementation in a few months before pregnancy starting. So you may well have a lady who comes to you and she wants to become pregnant and she wants preconceptual advice. That's absolutely fine. There are certain things she should be doing, which, for example, we need to be looking at folic acid supplementation, good diet, healthy exercise, reducing alcohol intake, reducing smoking, looking at lifestyle advice. That would be really helpful. The other thing that we perhaps need to do as well is to make sure she's not on any medications that are there for the skin condition or any other sort of medications, and get her just to have a chat to the GP to get a proper review of what medications she's actually taking at the time and whether or not they may well be contraindicated in pregnancy. So the British National Formulary for Children 2008 and subsequent versions as well just identify that drugs should only be prescribed during pregnancy if the expected benefit to the mum is thought to be greater than the risk to the fetus. So the expected benefits have to outweigh the risks that we have. And that's the same with any drug at all, fetus or no fetus. You're always weighing up benefits and risks. What we do tend to look at is offering the smallest effective dose, and the reason for that is just to try and reduce those side effects. There's quite a few drugs that are cited as having been extensively used in pregnancy and tend to be usually safe, but the problem is when you do start looking in the BNFC and you start to look at phase 1, phase 2, phase 3 trials and everything else that come through, it's very, very difficult ethically to test any medications and drugs on pregnant women. With that in mind, there are very few drugs that will say absolutely safe during pregnancy. On the converse side to that, there's a couple of drugs that have actually really been identified as causing problems in fetal development. Anything that causes problems in fetal development is called a teratogen, so it is teratogenic. No drug is safe beyond all doubt in early pregnancy. But what we can say is that there are certain drugs which do have certain significant risks, which would mean that you would never prescribe them. The most important thing to say is absence of information in the BNFC or the BNF or any other drug, any other sort of drug formulary that you use. Absence of information does not imply safety. for use in children, maternal health, and prescribing in pregnancy and breastfeeding. One of the most important things to consider when you are prescribing for a pregnant woman is that drugs can harm the fetus at any time during pregnancy. Now, you might be slightly different to myself. I had no idea I was pregnant until I was about 5 weeks gestation with my twins and my singleton pregnancies that I had. Many women are not aware that they're pregnant, sometimes for the first 3-4 months of pregnancy. It is absolutely essential that we know that drugs can harm the fetus at any time during the pregnancy. So we really do have to bear this in mind when we're looking at any females of childbearing age. Also for men trying to father a child. And the reason for this is because there can be some drugs that are secreted in the semen, for example, which can cause disorders of fetogenesis and problems with fetal development. When we start looking in, we normally chop a pregnancy into trimesters, so we chop it into 3. So the first 3 months, first trimester, second 3 months, second trimester, third 3 months, that final third trimester. During that first trimester, you can get serious congenital malformations because it's then that you've got organogenesis, so the fetal development is moving to, all of the organs are generating, everything's all becoming compatible with life. During the second and third trimesters, they can affect the growth and the functional development, and that's fine. They can have toxic effects on certain tissues and fetal tissues, and some drugs that are just given before term or during labour can have adverse effects on either the labour or the neonate after delivery. So it's really important to know that whatever you're giving the mum will affect the baby potentially. So what we're trying to avoid here is any substance which is going to cause any fetal damage, any impairment of growth or development, any types of malformations or abnormalities which are caused by exposure to either medications or other types of exposure, so environmental things such as carbon monoxide, tobacco smoking, alcohol intake, all sorts of other things that have been identified as having causative problems with the fetal growth and development. So we know that tobacco smoking can cause fetus to be smaller and to sort of developmentally just to be slightly delayed in relation to growth and development. We know that certain drugs can affect babies' development in utero. In the first trimester, you tend to find that these drugs will affect things significantly, whereas in the consequent trimesters, you do tend to find that some of these exposures will just relate to either growth and development. There are some type of antibiotics that you can administer, for example, which will cause impairment of growth and development of the fetal teeth in utero. So it's really important that we understand what this is about and what it means. For you as healthcare providers and practitioners, the most important thing is that we have this UK teratology information service, and that's available via this hyperlink here. So if you're ever concerned about anything and you're wondering about whether or not something's going to cause harm or damage to a lady who's pregnant, feel free, have a look at that UK teratology information service.org, and that's regularly updated. This slide presents by no means an exhaustive list of drugs and things that we know will cause problems to the fetus as it's developing. So ACE inhibitors, we know that during all trimesters it's going to potentially affect the renal development of the neonate. Tricyclic antidepressants, if given in the third trimester, can actually cause the neonates to start to offer some type of withdrawal syndrome, and they will exhibit types of dependence and withdrawal activities that you would see in adults as well. So high-pitched cry, potential fitting, signs that are attributed to dependence on a particular medication. Same goes for barbiturates as well. Carbamazepine is a drug that's been identified in the first trimester to potentially be linked with neural tube defects. Drugs such as cocaine, tamoxifen, there is an increased risk of spontaneous abortion, probably because during the first trimester you're going to see catastrophic effects to multi-organ and multi-system problems. Ethanol, alcohol, this can contain, this has been linked quite closely with fetal alcohol syndrome. We still actually don't know what the safe levels of alcohol are, so we always sort of suggest to any pregnant ladies that, you know, that withdrawing or reducing alcohol is significant and is really important. Fetal alcohol syndrome comes with a number of features in the sufferer, so an elongated philtrum, widened eyes, lowered ears, reduced mental status, and a number of other things as well. Iodine can cause congenital goiter or hypothyroidism. Lithium can contain increased intracranial pressures. Tobacco, we do know any smokers, mums who smoke all the way through the pregnancy are likely to experience smaller babies, so intrauterine growth retardation. Tetracycline is the antibiotic I mentioned earlier on, which will cause discoloration of teeth because it works on the calcium pathways, and that'll cause discoloration of teeth and altered bone growth in the neonate, in the fetus. We all know about the stories of thalidomide causing the limb malformations, which, you know, happened in the 70s, 60s, so we're aware of that. Now, warfarin's also a drug that, you know, is quite commonly prescribed, but what you find is in the first trimester it can alter the respiratory tract formation in the fetus. In the second trimester, if given, it will cause potentially central nervous system malformation, and in the third trimester then you've got this sort of, once organogenesis has been completed, you start to look at the risk of bleeding and intracranial hemorrhages. And here's another link to a site that the Medicines Healthcare Regulatory Authority and the National Institute for Clinical Excellence offer as well. This just tells you about what types of things you can and can't prescribe during pregnancy and contraception. In a few minutes, I'm going to ask you to double click on the YouTube link. And this YouTube link will talk you through, will just show you the development of the embryo. So you start off with the embryonic disc and the sac. You start to move, develop as placenta. You can see the mouth and the jaw starting to develop. You can start to see the heart, and that primitive sort of tube changes into a face and cells. You start to see circulation. At month 2, you start to see the ears develop, leg buds and eyes, the neural tube and the digestive tract starting to develop and increase. At month 3, you start to see the arms, legs, fingers, toes fully formed, and you'll see all this in the YouTube video that I've got showing you in a few minutes. You start to see toenails and teeth developing. You start to see all organs are present, but they're really, really immature. And then you can see the twitching movements. The twitching movements will start from about week 8. So you start to feel flutters when you're pregnant with a baby, around about week 8. But the fetus is so tiny at that stage. Many women don't feel this. But you do see those jerks, and then they start to move into basic fetal movements by around about month 3, which is 12 weeks of pregnancy. By month 4, you start to see the baby developing eyelids and eyebrows, small amounts of hair called lanugo, and the lashes will start to develop, and you start to see that. The fetal movements become more pronounced, and you start to see the nervous and reproductive systems to really develop and focus into where they're going and how they're developing at the time. Around about 24 weeks, 23, 24 weeks, you'll start to see the eyes start to open as well. Eyes being fused is something that you look out for when you're in neonatal units, and you start to see sort of the single cell thick skin developing and the eyes opening, and a lot of other things that happen that are around about that level of viability. By 6 to 9 months, all the babies are doing there is just trying to add fat increasing responses to stimuli as the central nervous system starts to really increase. Amniotic fluid starts to reduce a little bit. You start to see the brain developing really rapidly, getting ready for extrauterine life. You start to see movements becoming coordinated, and you start to see the maturation of all of the internal organs. So I'll get you just to double click on this fetal development YouTube video, and I just want you to think, as you're looking at how the baby starts from basically a clump of cells to a line, which then folds in on itself and turns into the embryo, and then moves into, you know, the development that you can see with the legs and the eyes and the ears and everything else. And I'll show you this next slide once you've looked at the video, to be able to give you some sort of explanation as to how that really impacts what we can prescribe and when we can prescribe it. So hopefully you saw on that video how we started with that embryo and the embryonic disc, how you turned into sort of almost like a line, which then developed and folded in on itself. And you can almost see that folding in is how things like the heart are developed, how the lips and the palate and the mouth are developed, when the ears are developing, and why on earth things like the low set ears can be a sign that other things are going on. Now this is really, really important to know, because when you are prescribing anything, you prescribe it in weeks 2, nothing's necessarily going to happen because the disc hasn't embedded into the maternal circulation yet. Not too much is happening. Week 3, 4, 5, 6 and onwards to about 16, you're still developing significant proportions of organs that you need to manage the outside world and sort of manage extrauterine life. So that first 3 to 16 weeks, you're looking at significant problems with neural tube defects, with central nervous system sort of development. 4, 5, 6 weeks gestation, you're looking at all the heart problems. So, you know, atrial septal defects, ventricular septal defects, tetralogy of fallow, and problems there that can happen, because you can see certainly during weeks 4, 5 and 6, that's the time, the crucial time, that this is happening, this is development's happening. Now if you do start to notice, and you're doing a baby examination and you do start to notice a tetralogy of fallow or an atrial septal defect or a ventricular septal defect, you start to looking at other things as well. So you start to look at, what does the lip look like? Is there any cleft of the lip or the palate? What are the ears like? What are the eyes like? These things are all developing at exactly the same time during the fetal development stage. So if something's affected this baby during weeks 4 to 6, it might well also affect not just the heart, but the lips, the ears, the eyes, and other sort of aspects. So it's always worthwhile just having a look back when you are doing any sort of assessment of a baby. If you do find one thing, have a look at everything else that's sort of developing around about the same time when you're looking at the fetal development. Embryology is utterly fascinating, and I used to love looking at this when I was looking after neonates in the intensive care units. So we'd do baby examinations, and you'd know full well that if you had a baby that you were a bit unsure about the heart, and you'd be listening to that, I'd check the mouth out just that little bit more carefully. I'd check the ears out just a little bit more carefully, just to see how things were going. Bit later on, you start to look at upper limbs, lower limbs and the developments, extra digits, missing digits, where are the ears, where are the eyes, what's the palate feel like, what's the genitalia external like, how's that growing and developing, and what things might have affected each organ at certain clinical development phases during the embryological phase. So this one's just a really quick snapshot. When do we start to grow and develop? So we've got central nervous system, 3 weeks to full term, ears 4.5 weeks onwards, teeth 6 3/4 weeks to full term, palate 6 3/4 weeks to sort of 16 weeks. That will be fused by then. Upper limbs are growing and developing from 4.5 weeks to 9. External genitalia, week 7 to full term. The lower limbs, again, same as upper limbs, 4.5 weeks to 9. Heart, 3.5 weeks to 9. This is really crucial because most women don't know they're pregnant until they're around about 8 to 10 weeks. By then, the hearts, the eyes, the ears, upper limbs, lower limbs are likely to have started to develop. So who knows what environmental things these babies, these fetuses may well have been exposed to. So one thing I would say is, no matter what happens, the body has a most beautiful protective mechanism as well. So we always have the mum's body, the mum's circulation there that will actually absorb a lot of risk for the fetus. If we are going to think about drugs and how they're going to affect mum and baby, we have to think about, first of all, how is it going to work in the maternal body? And this is where we look at pharmacokinetics and pharmacodynamics of any medications. So first of all, how is it absorbed? How is it distributed? How is it metabolized, and how is it excreted by the maternal body? Does the drug cross the fetal placenta? Will it bypass that fetal cellular membrane, which is that beautiful placenta and all of the protective mechanism we have there? In the maternal system, we have to think about the again ADME, so absorption, distribution, metabolism, and excretion. What's the half-life of the drug? What's the clearance rate of the drug? Does it stay in the system for a long period of time? In the fetal system, again, how's it metabolized? What's its half-life? What's its clearance rate? And remember as well, we all react to medications in slightly different ways. Take the CYP2D6, so the cycloprotein 2D6 mechanism for codeine metabolism. If you start to think about that, we know that around about 10% of people will be rapid metabolizers of codeine. They're the ones that will be completely and utterly high after one cocodamol tablet, for example. How do we know the fetus isn't going to be a CYP2D6 rapid metabolizer if the mum is or isn't? We don't know that, and that's why we have to really be aware that we have two different systems working in one body which are going to affect and metabolize, and their ADME mechanisms are slightly different between each other. So we have two systems, mum and fetus, and two different absorption, distribution, metabolism, and excretion mechanisms. And it's always worth knowing that and thinking about that one to point out. So there are a number of differences with pharmacokinetics and pregnancy as well. So what's happening in the maternal body to make the absorption, distribution, metabolism, and excretion of a drug slightly different during the pregnant cycle? So first of all, your total body water can increase by as much as 8 litres during pregnancy. Now this is going to affect the volume distribution, so that's going to affect your water-soluble drugs, for example. Think about drug binding as well, the changes in concentration that you have with serum proteins, which is going to be increased in your pregnant ladies, which increases the unbound active fractions of medications and proteins. The liver metabolism increases during pregnancy as well, but liver blood flow doesn't. So that's going to have different effects on how you metabolize drugs. Your renal function increases, and you've also got all of this extra total body water that's flushing through the system. So that's going to increase renal elimination of medications as well. So when you are prescribing for pregnant ladies, it's a balancing act as to how you're going to measure and analyse all of these things at the same time. Now, your total body water doesn't increase by 8 litres during the first trimester, but it certainly will be up there in the third trimester. So it's not just necessarily about pregnancy per se. This is about pregnancy from start to finish, and analysing and assessing and evaluating absorption, distribution, metabolism and elimination during each phase and stage of pregnancy. So the placenta gives us another beautiful buffer between maternal and fetal circulation, and it's there really to sift out anything that might well be harmful to the fetus. But obviously, as we've talked about already, there are certain substances which will cross that placental membrane. To be able to cross the placental membrane, you have to be able to get into the mum's blood vessels, through to the fetal blood vessels, into this intravillous space, and you have to be able to be absorbed through the fetal blood cells as well, the fetal blood vessels as well. This placental membrane gives you a beautiful buffer between mum and baby to buffer a significant number of potential teratogens and potential substances which are harmful and hazardous to health for the fetus. So if you are prescribing any medication, the good thing is you know full well now you've got to have, the mum's got to be able to absorb the medication, absorb it into the bloodstream, and then from the bloodstream it's got to get through the placental membrane into the fetus. So already we've got a number of mechanisms there that are protecting the fetus from harm during pregnancy. Any fetus, really, it's almost a parasitic relationship. So the fetus will get what it wants to from the mother at the cost of the mother's benefit and at the cost of the mother's health. The fetus will take what it needs. I always put this slide up because it just introduces pharmacokinetics. Pharmacokinetics is a way which the drug will actually get into the drug will get into the site of action. So it's just really to show you that in addition to the barrier, which will be the gastrointestinal tract, the first pass through the liver, the IV or the IM sort of tracts and all of the barriers that possesses, as well as the fetal membrane, as well as that placenta, you've also got this barrier across the cell membrane. So for example, the cell membrane offers a nice little sort of microcosm of barrier as well. So certain drugs can only get into it if it has the specific required biotransport mechanisms. So for example, we know that sodium will get into a cell if it's going from a high to a low concentration gradient. We know that certain proteins need a carrier-mediated transport system to be able to get them into the site of action. We know that certain drugs are ionized. We know that certain drugs are lipid soluble. And these things all need different mechanisms to get them to the cells where they can actually affect a change. And basically that's it. That's what I'm trying to get to here. And it's again just to show you that in addition to all of the other sort of processes that the fetus have got, these drugs, these teratogens, these things that we want to take action have still got to pass not only the placenta, not only the gastrointestinal tract, but they've also got to then pass that barrier, which is the cell membrane. So when it all comes down to it, what can we basically do? Well, for yourselves as district nurses and community nurses and health visitors and paediatric nurses and school nurses, the one thing that we can do is just understand that maternal health comes with an altered physiology. We know that mum's got more water on board, she's got the placental barrier that's going to be there. The thing that we can affect to change is to suggest the folic acid in the first trimester and give lifestyle advice about smoking cessation, about alcohol and drug use. And we understand what the implications of alcohol, drugs and smoking can have on fetuses. We know that they will cause deleterious effects. One thing that we do need to mention as well is sometimes women can be taking herbal remedies. So just be aware about what sort of over-the-counter medications they're taking and what sort of effects and side effects they could have. The most important thing is communicate with your ladies who want to become pregnant or communicate effectively with those people who are already pregnant as well. Empower them. They're the ones that are making the choices for themselves. They're making the lifestyle choices for themselves. They've got enough going on at the time. The last thing they want is unsolicited advice. So we work with women. We empower women to make choices that they want to make, and we can offer as much advice as they want. That may well involve preconceptual advice as and when it's within the limits and the bounds of your competency.